welcome everybody to today's class on myocarditis. Me, Dr. Nur Alam, Associate Professor, Cardiology, NICVD. Just going to start the class. So, slide transition is okay, no? You're seeing the myocarditis and myocarditis in COVID-19, okay?
Yes, sir.
Okay, thank you. So, I will discuss on 2 parts of my lecture. One is myocarditis in general, and second part will be the myocarditis in COVID-19 era. So, myocarditis, if we consider the definition that is adopted by ESC 2016, myocarditis is an inflammatory disease of the myocardium and is diagnosed by established histological, immunological, and immunocytochemical criteria. So, inflammatory disease of the myocardium, the histological diagnosis is based on endomyocardial biopsy, and other forms may be by cardiac MRI. So, this is a picture of myocardium, normal myocardium, having myocardial cell with syncytium. But this is a healthy myocardium. But this myocardial histological picture of myocardium revealed that damaged myocyte, cardiomyocyte is damaged, and there is infiltration of the inflammatory cells like phagocytes, lymphocytes, natural killer cells, and others. So, healthy myocardium, when got infected, the pictures is like this: the myocardial damage as well as infiltration of the inflammatory cells, and patient begin to suffer or having symptoms. So, please mute everybody. If you have any question, then you can unmute. No problem. You can unmute yourself. Otherwise, if you don't have any question or you don't need to ask anything or any comment, just mute yourself. You may unmute yourself also as you like, any point of lecture. Thank you. So, what are the etiology or the causes of the myocarditis? A large number of causes of the myocarditis have been identified, like virus, fungus, bacteria, parasites, toxins, drugs, and immunological reaction and physical insult also. So, a large number of causes of myocarditis have been identified, but often a cause cannot be found. Sometimes there might be no cause. No cause could be detected. In Europe and North America, viruses are common culprits. Worldwide, however, the most common cause is Chagas disease, an illness endemic to Central and South America that is due to infection by the protozoa Trypanosoma cruzi. The most common Chagas disease, that is a protozoal disease, and the name of the agent is Trypanosoma cruzi. In viral myocarditis, the main virus is the Coxsackie B family. Coxsackie virus B3, Coxsackie virus B5 are the most frequent cause. And nowadays, in this era, SARS-CoV-2 virus is also contributing the most of the myocarditis presenting in this era in COVID pandemic. So, what are the infections? Infectious agents, among the viral agents, adenovirus, parvovirus B19, Coxsackie virus, rubella virus, polio virus, EB virus, hepatitis C virus, and of course, last but not the least, severe acute respiratory syndrome SARS-CoV-2 virus. Among the protozoa, as I just mentioned, the Chagas disease caused by Trypanosoma cruzi and also the Toxoplasma gondii. Among the bacterial, as we know, the Corynebacterium diphtheria was an important cause of myocarditis in the in the late of 20th century, last of the 1980 or like this. But now it is almost obsolete due to antibiotic and other drugs. So among the bacteria, Brucella, Corynebacterium diphtheria, Gonococcus, Haemophilus influenzae, Actinomycosis, Trophorrima whipplei, Vibrio cholerae, Borrelia burgdorferi, Leptospirosis, and Rickettsia, and Mycoplasma pneumoniae also. And among the fungus, Aspergillus, parasitic, Ascaris, Echinococcus granulosus, Paragonimus, Westermanni, Schistosoma, Trichomonas oleum, Trichinella spiralis, visceral larva migrans, and Wisteria bancrofti. Note that bacterial myocarditis is rare in patients without immunodeficiency. So among the toxins, drugs including alcohol, anthracyclines, these are the chemotherapeutic agents, and antipsychotics like clozapine. And lot of immunological causes are there that causes myocarditis. There is acetazolamide. This drug is used to reduce the glaucoma pressure, eye pressure. Amitriptyline also, immunologic reaction. Rejection after heart transplant. Autoimmune diseases. That autoimmune diseases may cause myocarditis like scleroderma, SLE, sarcoidosis, systemic vasculitis, like eosinophilic granulomatosis, polyangiitis, Kawasaki disease, idiopathic hypereosinophilic syndrome. These all autoimmune disease may have autoimmunity against myocardium and produce myocarditis. Toxins like arsenic, toxic shock syndrome toxin, carbon monoxide, and snake venom, and also heavy metal, copper or iron. Physical agent like electric shock is an important cause of myocarditis. Even hyperpyrexia and radiation injury to the myocardium may cause myocarditis. So there are a lot of agents that autoimmune and viral, fungal, bacterial, and protozoal disease also that may cause myocarditis. And sometimes it is also to be remembered that sometimes no cause may be found in myocarditis. So now this is the very important slide. May I request everybody to concentrate on this slide? Though the text font is smaller, but as this is the direct copy from the ESC 2013 task force, that's why I couldn't make it a larger font. But I think you will all able to understand if we go slowly and if we concentrate. So, what are the diagnostic criteria of the myocarditis? These are the clinical diagnostic criteria that is adopted by ESC in 2013. There are some clinical presentations, clinical criteria, and there are few investigations criteria. And finally, the diagnosis of myocarditis will be made both combination of this clinical and diagnostic criteria. Let us see what are the clinical presentation of a myocarditis patient. You see, the clinical presentation may vary, may start as usual cardiac symptoms like chest pain, acute chest pain. The chest pain may be pericarditic or pseudo-ischemic, and chest pain along with there may be dyspnea or fatigue. Dyspnea may be new onset or chronic dyspnea. Dyspnea may be dyspnea or fatigue may be with or without heart failure signs. And there may be also chest pain, dyspnea or fatigue. Dyspnea or fatigue may be in rest or with exertion. Dyspnea or fatigue may be with or without left or right heart failure. There may be palpitation, There may be unexplained arrhythmia symptoms. There may be syncope. There may be aborted sudden cardiac, reverse from sudden cardiac death, and unexplained cardiogenic shock. So you see the symptoms, most likely all symptoms of the cardiovascular disease, cardiac disease, starting from chest pain, dyspnea, fatigue, palpitation, syncope, and cardiogenic shock. All may be present in a myocarditis patient. And these are the clinical presentation. And what are the diagnostic criteria? The diagnostic criteria may be in ECG, Holter, or stress test features. What might be the ECG changes? As we know, there may be ST changes, ST elevation, or ST depression, or non-ST elevation, or T wave inversion. And other features may include, you see from the essay note, there may be sinus arrest, there may be supraventricular tachycardia, there may be AV block starting from first degree to third degree heart block, there may be bundle branch block, there may be reduced height of the ROL, there may be abnormal QRS, there may be low voltage, there may be frequent PVC as well. So you think the ECG or Holter or stress test may reveal in myocarditis like ST change, ST elevation, ST depression, all sorts of arrhythmia like atrial fibrillation, ventricular fibrillation, AV block, supraventricular tachycardia, and also bundle branch block and PVC and abnormal QF. So wide range of presentation there may be in myocarditis in ECG and or Holter or stress tests. So other myocardiocytosis marker, that is biochemical test, may be elevated troponin T or troponin I. And you see, third point is the important point is the functional and structural abnormalities of cardiac imaging. Imaging include echo, angiography, and cardiac MRI, cardiac magnetic resonance. So what findings there may be? The echo is an important factor in the diagnostic criteria. So there may be, you just remember that, or you just note that unexplained LV or RV structural and functional abnormality. Unexplained LV and RV functional abnormality. What is the functional abnormality there? There might be regional all motion or global. Usually we get global, but there might be regional all motion abnormality in systolic and diastolic function abnormality. With or without ventricular dilatation, there may be ventricular dilated or not dilated, with or without increased wall thickness, with or without pericardial effusion, with or without endocavitary thrombi. So there may be there may be wide range of presentation in echocardiography. So just note that if on gate the unexplained LV or RV structural and functional abnormality, what are the structural abnormality? There might be regurgitation, valvular incompetence. What are the functional abnormality? There may be diastolic or systolic dysfunction. The systolic dysfunction might be regional or global. Most of the time we get global, but regional all motion abnormality might be present. This functional or structural abnormality may be with or without ventricular dilation, with or without increased wall thickness, with or without pericardial effusion, with or without endocavitary thrombi. So these are the imaging characteristics. And last four is the tissue CMR imaging characteristics, that is MRI imaging characteristics. This is very important that in certain later slide I will show you that certain diagnosis of myocarditis will be dependent on cardiac MRI, where cardiac MRI may reveal LGE, late gadolinium enhancement. There is a specific characteristics of MRI findings of gadolinium enhancement, and that is will be presented as late gadolinium enhancement of classical myocarditis pattern. So these are the clinical presentation, symptom signs, and these are the investigation characteristics of myocarditis. But when we will diagnose myocarditis among all these, if we have one or more the clinical presentation, may say chest pain or breathlessness, and chest pain and breathlessness, chest pain or breathlessness, and one or more of the diagnostic criteria from different categories, like in so if there is a symptoms, chest pain or breathlessness or syncope or palpitation with either ECG or echo or cardiac magnetic CMR test, so this combination we make clinical diagnosis of myocarditis. In asymptomatic patient, at least two diagnostic criteria should be made. Two diagnostic criteria. Those patients having no symptoms, zero symptoms, then two diagnostic criteria, two investigation criteria is needed to diagnose it. But last but not the least, this is very important. All of you should note on this. After exclusion of coronary heart disease, before diagnosis of myocarditis, you fulfill the clinical criteria, but it should be confirmed that there is no coronary artery disease, there is no cardiac defect, no congenital anomalies. This is important. After exclusion of these coronary artery disease, cardiac defect, and congenital anomalies, then you can able to diagnose with this criteria. And this is an important slide, that if we want to diagnose certainly this is a myocarditis, we can diagnose clinically with investigation and excluding coronary artery disease by angiogram. Then we can then we can make a diagnosis that this is a myocarditis. But if we want to be sure, but there is a confirmatory diagnosis or diagnosis of certainty of myocarditis is based on tissue characterization by MRI, cardiac MRI, that will reveal the edema, or that I mentioned, late gadolinium enhancement of classical myocardial pattern, and endomyocardial biopsy if possible. Biopsy result will reveal that infiltration of leukocytes, phagocytes, and eosinophil. And in case of RT-PCR, in case of COVID, we can do the biopsy material RT-PCR. And finally, if needed, autopsy. So, certainty of the myocarditis diagnosis, if we want to be confirmed, then you have to diagnose by tissue characterization by cardiac MRI and endomyocardial biopsy. So, we'll move to next slide. So, what is the treatment? As with most viral infections, symptomatic treatment is only form of therapy for most forms of myocarditis in the acute phase. Supportive therapy, including bed rest, is indicated. Before going to next slide, I just remind you that the Zoom meeting may be ended. You just rejoin with the same link. You are requested to rejoin in the same link after Zoom meeting ended. Within 5 to 7 minutes, this may be ended. Anyway, so as with most viral infections, symptomatic treatment is the only form of therapy for most forms of myocarditis. In acute phase, supportive therapy, including bed rest, is indicated. In people with symptoms, diuretics may help, along with other heart failure treatments. For people with moderate to severe dysfunction, cardiac function can be supported by use of ionotropes. What are the ionotropes suitable for myocarditis? Is milrinone and dobutamine. Sometimes noradrenaline may be helpful. Followed by oral therapy with ACE inhibitors when tolerated. What about systemic corticosteroids in myocarditis? May have beneficial effects in people with proven myocarditis. However, data on the usefulness of corticosteroids should be interpreted with caution, since 58% adults recover spontaneously. A 2015 Cochrane review found no evidence of benefit of using IVIG, intravenous immunoglobulin, in adults, and tentative benefit in certain children. There may be tentative benefit in children. There may be benefit of IVIG, intravenous immunoglobulin. It is not recommended routinely until there is better evidence. And people who do not respond to conventional therapy may be candidates for bridging therapy, like a ventricular assisted device. Maybe heart transplantation is reserved for people who fail to improve with conventional therapy. And extracorporeal membrane oxygenation may be used in those ECMO. ECMO may be used in those who are about to go to in the cardiac arrest. So regarding the treatment, corticosteroid treatment, the recent recovery trial, I will show the slide later. Recent recovery trial recommend the corticosteroid in moderate to severe symptoms, especially in hospitalized patients. So now we will move to our second part of the lecture, myocarditis in COVID-19 era. The second part of the lecture, myocarditis in COVID-19 era. So there are two terms, myocarditis and myocardial injury. In COVID-19, there are two terms, myocarditis and myocardial injury. What are the mechanisms of cardiac injury? What are the mechanisms of cardiac injury in COVID-19 patient? There may be viral invasion, direct viral invasion, or indirect effect. Indirect effect means the effect that is by immune response of the body to the virus. So these two mechanisms, there may be myocardial injury. So if you consider this slide, in COVID-19 infection, how the myocardial or heart is infected or involved or injured. We all know ACE2 receptor mediated direct damage. The virus bind to the ACE2 receptors and invade the myocardium. That will sequentially increase affinity to the ACE2, reduce ACE2 expression, dysregulation of the RAS system, and hypoxia-induced myocardial injury. That is type 2 injury. As we know, lungs is involved first, or ARDS, so there may be hypoxia. That hypoxia may injure myocardial cell as well as other tissues of the body. So what happens there in hypoxic injury? Oxidative stress, intracellular acidosis, mitochondrial damage. So cardiac, and these are the AC-mediated direct injury. These are the hypoxia-mediated injury. This is called type 2 injury, and this is the cardiac microvascular damage. These are the mostly now most autopsy reports and most recent data reveals, and they emphasize on this type of injury of myocardium in COVID-19 disease. These are the cardiac microvascular damage. So there may be inflammation in the vessel, there may be vessel occlusion, thrombosis, and there is a perfusion defect, vessel hyperpermeability, and angiosperm. And lastly, the myocardial injury may occur due to systemic inflammatory response, the immune response of the body to the virus. This is cytokine storm and dissolution of the monocyte and uncontrolled inflammation. There is a high interleukin-1, interleukin-6, interferon gamma, interleukin-1 inhibitors, interleukin-6, and these are now the target of the treatment in advanced critical disease of COVID-19, myocarditis. You can target these cytokines. If we block or inhibit these cytokines, there might be benefit. That's why the interleukin-6 inhibitors and JAK inhibitors are supposed to play a role in critical COVID-19 disease to treat myocarditis by blocking or inhibiting these inflammatory markers. So this is the another picture, that is SARS-CoV-2 just invade by S inhibitor, SE2 receptor invade the cell, going to the lungs, and then inflammatory response occurred. The inflammatory markers in the system and systemic inflammation. These are the blood vessel. This inflammatory response. The inflammation response develop thrombus and lead to heart attack, pulmonary embolism, strokes. There is a paper, this is very important, there is a paper that many STMI patients with COVID-19 have no obstructed arteries. You see, perhaps already you have shown or you have gone from this type of paper. Many STMI patients with COVID-19 have no obstructed arteries. A case series of 28 STMI patients from February 20 to March 30 in the Italy, 39%, 40% didn't have any obstructed artery. In their paper, the researchers note that they could not determine whether the STMI, those STMI with no coronary artery disease in this group was attributed to, if there is a type 2 MI, then this is type 2 MI, that is hypoxia related injury, not type 1, that's not involving the coronary artery or coronary artery plaque. Is this group, those group of patients, STMI without normal coronary artery, maybe myocarditis patient, or maybe endothelial dysfunction related to the infection, not having coronary artery disease, or maybe cytokine storms. They attributed these things. These STMI patients, 40% of them with no coronary artery disease, they shown that there was no coronary artery disease, and they speculated or they predicted that this group of patients might attributed to type 2 MI, there is hypoxia, there may be myocarditis, that is our concern. So we already know that myocarditis patient might have ST elevation. We already know from the diagnostic criteria, or there might be endothelial dysfunction that is produced injury and ST elevation, or that may be related to the cytokine storm. So many STMI patients with COVID-19 have no obstructed arteries. The finding supports an anecdotal reports of STMI mimics, but not a role of fibrinolysis for STMI patients during the pandemic. What is anecdotal reports? Anecdotal reports means this is not a randomized control trial, or this is not a trial result, non-randomized trial result, not a study result, but anecdotal reports means someone observation, but some. So this slide reveals that troponin I elevation is how much consistent or how much relevant with diagnosis of COVID-19 patients. Can we exclude or include myocarditis by seeing troponin I? So as we mentioned that troponin I may raised in a lot of causes other than cardiac causes, other than cardiac disease, and especially in COVID-19 disease, there may be other causes like respiratory infection, ARDS, and other causes which may reveal rise of high sensitive cardiac troponin. This is an important that acute myocardial infarction, either type 1 based on plaque rupture, possibly triggered by the infection, or type 2 based on this type 1 or type 2. Both cases, type 1 means plaque rupture due to COVID infection, unstable plaque, patient having unstable plaque in the coronary artery and ruptured by the COVID-19 infection, or there may be hypoxic injury that causes type 2 MI. These both type 1 and type 2 MI is possible. So in these both cases, there may be rise or fall troponin. So troponin I is not sufficient for the diagnosis in COVID-19 disease that cause MI, which should be based on. So the diagnosis of MI in this COVID era should not be based on only troponin I, should be based on the clinical judgment, symptoms, signs, and ECG changes. And this is important that abnormal troponin level is not equivalent to myocarditis or acute MI. this is an important that the troponin I, ECG guidance, ESC guidance for the diagnosis and management of cardiovascular disease during the COVID-19 pandemic. The troponin I is a mortality predictor of the patients. Those are admitted in hospital. On data shows that this red line are the patients are non-survivors, and the blue line are the patients of survivors. These are the level of the troponin. You see, the patients got admitted in hospital with COVID-19 infection. Those are non-survivors, having most of the time their troponin is raised, and the survivors' troponin was not raised. So this might be considered troponin. This troponin might be considered as a mortality predictor in this COVID-19 pandemic. And this is an important. If we consider the troponin as a quantitative data. So what might be the inference, or what might be the reference? So if a patient in COVID-19 era, if a patient having the this is the 20 is the upper limit of the normal level. If there is a threefold rise, this might be cardiac disease like type 1 MI, or this might be heart failure, or the pulmonary embolism, or ARDS. At this level, 3 times may not require treatment. But if there is more than 5 times, there might be a chance of type 1 MI definitely, or myocarditis, or Takotsubo cardiomyopathy, or shock. So if 5 times or more raised, so we should consider that this is might be solely due to cardiac disease like myocarditis, shock, or type 1 MI. And up to 3 times upper limit of the normal level, there might be MI, but also the other cause, and sometimes there might be no significant to give treatment. This is an important slide. I think all the in this COVID era, you are doing duties in the CCU or emergency or trials. So some patients came with ACS mimics, like the ACS may be COVID or non-COVID. These ACS may be due to myocardial injury, or this is maybe ACS or myocardial injury or myocarditis. So as all the investigation are not feasible in certain time period in this COVID-19 era, how we can differentiate? So there are some clinical criteria for differentiating ACS, myocardial injury, and myocarditis. ACS patient having typical history of chest pain, radiation, that chest pain we usually describe in patient presenting with unstable angina or ACS. Typical chest pain, risk factors. There may be typical ECG changes like inferior leads or anterior leads, ST elevation. Also, there may be raised biomarker in echo, raised residual motion abnormality, and coronary artery disease. We can detect coronary artery disease might be detectable. And in myocardial injury by SARS-CoV-2, there may be, of course, if COVID infection, there may be history of fever, cough, sore throat, dyspnea, diarrhea, and various type of ECG changes. There may be also raised biomarkers, LV or RV dysfunction in echo. And as there is a SARS-CoV-2 infection, blood and inflammatory markers may be raised. Chest X-ray and HSCT, there may be ground glass opacity. COVID test also positive. And if we consider the myocarditis in this group of patients presented with chest pain or dyspnea or having ECG changes, so there may be similar type of evidence. And echo we consider, as we already know that there may be regional motion abnormality, but most of the time there is a global motion abnormality, and histologic evidence histologic and MRI evidence needed to confirm the diagnosis. So these are the differentiate criteria, but still there is a gray zone. These three point ACS or SARS-CoV-2 myocardial injury or SARS-CoV-2 myocarditis may mimic same features sometimes. So COVID-19 test must be sent in suspected cases. If the report pending, could it be differentiated in other ways? As we know, a COVID-19 test report may delay 1 or 2 days. So what can we do? You are doing in the CCU, you doing duty in the CCU. So COVID report is pending. Then how can we differentiate? Is there any differentiating point between ACS or COVID-19 or myocardial injury or myocarditis? There are some data. The data in separating by CT imaging data that are heart failure in CT and COVID-19 in CT chest. Usually COVID-19 CT chest, COVID-19 infections CT chest usually have more peripheral distribution. The opacity, all these cases are, there is a ground glass opacity or opacity, but distribution type and lesion morphology may have some idea, may give some idea that it is a COVID-19 disease or a plain SCS heart failure. So opacity in the COVID-19 disease mainly in the peripheral distribution. Heart failure are more likely to have a central and gravity associated distribution. Central distribution. This is a peripheral distribution. Rounded morphology and usually has more peribronchovascular thickening and other features like in heart failure without COVID infection, fissural thickening, subpleural effusion and cardiac enlargement. There are some lines, early B lines, early A lines, B lines. So most important are these are the peripheral distribution opacity. These are the central and gravity distribution. As there is edema, this is the gravity distribution and central distribution along with other features. So can this put this? We always not able to do CT of our patients. We might have some chest X-ray at best. So would we put these findings correlate with the findings of the chest X-ray? 4 different patients varying degree of COVID-19 pneumonia in chest X-ray, predominantly involving the peripheral lungs bilaterals. You see, these are the COVID-19 infected patients. Peripheral lesion, peripheral lesion, peripheral lesion, peripheral lesion, peripheral lesion, peripheral lesion. But in heart failure, you see there is the hilar vascular congestion, mainly the hilar vascular congestion, and there may be Carly V lines, there may be cardiomegaly, and there may be stabilization of the vessels. So, by considering the CT findings and correlates with these X-ray findings, we may have some idea that this is COVID-19 infection or this obesity is due to heart failure. This is also a heart failure picture, mainly the peribronchial bronchovascular region, the opacity seen. So, still there may be gray zone. Still, we are not able to differentiate because other symptoms may mimic. What then we'll do? We will just follow the guidelines. This is the BCI guidelines for management of STMI patient. If STMI patient having no history of fever, sore throat, or no suspicion of COVID, if there is symptoms is ECG mimic ST elevation, symptom less than 12 hours, no contraindication of fibrinolysis, then fibrinolysis. If more than 12 hours, then comprehensive treatment in CCU. If there is a contraindication of fibrinolysis less than 12 hours, or there may be unsuccessful fibrinolysis, then we can comprehensive evaluation, risk-benefit evaluation. If we have isolated cath lab or dedicated cath lab for PCI in COVID-19 patient, we can send the patient for cath lab. And this group of patients suspected COVID or confirmed COVID, we have to assess for fibrinolysis in the isolation room, in isolation ward. And if this is a high risk patient and these are high risk and shock patient, as if we have dedicated cath lab, we can send him to PCI or send him to dedicated cath labs COVID centers. And this is also American guideline for management of SCS patient. In SCS patient present very high risk, if we have dedicated cath lab, we can send him to cath lab for primary PCI. In STMI patient, low risk in STMA patient, if there is a confirmed COVID confirmed, then fibrinolytic therapy, low risk, COVID negative, we can send the primary visit for the primary visit. And also non-STS as the SC guidelines having the risk protocol, is very high risk patient, then we can send it to early immediate invasive procedure. And if not the high risk, very high risk, then we can guideline detected ischemia medical therapy. If after all these things still the gray zone remains gray, use your gray matter. You have to judge yourself according to the clinical features, risk factors, ECG indicators, and if possible echo findings. So you have to use your own judgment based on the clinical and investigation evidences. So treatment option for COVID-19 complications, steroid or not steroid. As we know that this already you have shown this slide of the COVID-19 infection. These are the stage 1, these are the stage 2, these are the stage 3. This stage 1 is the viral response phase, this is the pulmonary phase, this is the hyperinflammation, the body response to the virus. So up to this phase is mild, then it is moderate and severe. Mild, what are the symptoms in those phases? Mild constitutional symptoms, fever more than 90 degree, dry cough, diarrhea, headache. And these phases, shortness of breath, hypoxia, and these phases, ARDS. Clinical signs, lymphopenia in this phase, early phase lymphopenia, increased prothrombin time, increased D-dimer, and in this phase, abnormal chest imaging already 7 to 8 days in this phase. Transaminase level, low normal procalcitonin. And elevated in this severe phase, elevated inflammatory markers, CRP, LDH, interleukin 6, D-dimer, troponin, NT-proBNP elevation. So treatment protocol, as we already able to know that the remdesivir we can start in the early phase, but in steroid we can start at the phase 2 or stage 2. And in this phase, early phase, steroid are recommended, and other interleukin 6 inhibitors, interleukin 2 inhibitors, JAK inhibitors in this phase, that the pulmonary phase, moderate to severe phase. So these are the COVID-19 anticoagulation algorithm. I will not go to details. Already you have known by so many, seen by so many webinars. So this is a highly cited editorial by Lancet. COVID-19 considers cytokine storm symptoms and immunosuppression. All patients with severe COVID-19 should be screened for hyperinflammation using laboratory tests, increased creatine, decreased platelet, decreased ESR, increase in cytokines. In Wuhan, China, a study showed that non-survivors patient of COVID-19 infection having serum creatinine raised, and also interleukin 6, raised interleukin 6 or elevated interleukin 6, suggesting that mortality might be due to virally driven hyperinflammation. So in hyperinflammation, immunosuppression is likely to be beneficial. Interleukin on blockade, anakinra, showed a significant survival benefit in hyperinflammation without any adverse effect. And also tocilizumab, interleukin 6 blocker, has important findings. We have other options like IVIG, steroid, JAK kinase inhibitors, fedratinib, JAK2 inhibitors may also have benefit. Now just I will show some cases. A 69-year-old man from Italy was admitted emergency department with cough, very cough and fever and dyspnea. He initially reported vomiting and diarrhea 7 days back. He was immediately transferred to ICU because of the respiratory distress syndrome and severe hypoxia. He had a history of hypertension, control with bisoprolol 2.5 mg per day. Please mute yourself. And if this patient has ECG changes, as we see here, the ECG or LVH strain, and as well as there is T inversion in the other list. There may be, as the patient is hypertensive, concentric hypertrophy. In CT, there is ground glass opacity, peripheral location, And in cardiac MRI, there is a LG, late gadolinium enhancement. So these are considered Grace score was greater than 140, as we considered this is a non-STMI. Coronary angiography showed no disease. Cardiac MRI, LG, and endomyocardial biopsy not done. Antiplatelet therapy, anticoagulation therapy, statin are started at the suspicion of non-STMI. The patient got hydrocortisone at 11 for 9 days. The aim of reducing inflammation, particularly of the myocardium. The patient was weaned of mechanical ventilation after 3 weeks. So, why they suspect the COVID-19? As patient has history of diarrhea, vomiting. Patient presented with fever, cough, and worsening dyspnea. High Grace score, dynamic ECG changes, high troponin level, and normal angiogram. And as well as there is cardiac MRI showed late gadolinium enhancement. So, considering all these things, the patient diagnosed as myocarditis and treated accordingly. Another case, the patient presented with chest pain after an influenza-like symptom with clinical evidence suggestion of acute coronary syndrome. This chest radiograph shows that there is a ground glass opacity, there is opacity, and the ECG showed that STT changes both anterior and inferior list and also multiple PVC. So myocarditis suspected in this patient presenting as an acute coronary syndrome with evidence of all motion abnormality in echocardiography without evidence of obstructive coronary disease on coronary angiography. This is the third case. A 47-year-old presented with chest pain and breathlessness. Sorry. She was positive for COVID-19. Echocardiogram showed cardiac tamponade, and pericardiocentesis was performed. This was first reported case of COVID-19 associated cardiac tamponade. You see this is the cardiac tamponade. This is the fourth case, the last case. An 83-year-old lady treated with chronic hypertension was hospitalized for acute chest pain on 18 March 2020, associated with mild breathlessness and dry cough. Physical examination was unremarkable. ECG shows ST elevation in all lists and deep T inversion in other lists. High sensitive troponin was raised. Chest X-ray shows opacities, and coronary angiogram shows normal coronary arteries, and as well as LV shows typical Takotsubo syndrome, apical ballooning syndrome. So with this, I have to conclude my lecture with some take-home message that the certainty of diagnosis of myocarditis is based on tissue characterization by cardiac MRI. Then cardiac MRI may reveal edema or late gadolinium enhancement (LGE) of classical myocardial pattern. Or endomyocardial biopsy definitely might show infiltration of the leukocytes, phagocytes, and eosinophils. The clinical diagnosis is these are the definite diagnosis, and clinical diagnosis is on definitive criteria and exclusion of coronary artery disease, structural heart disease, and congenital anomaly. The criteria I have mentioned: clinical and investigational criteria. Myocardial injury occurs both in direct and indirect way in COVID-19. Clinical judgment is needed to diagnose and treatment of the cardiac complications. No evidence-based treatment for COVID-19 complication needs further randomized controlled trial. As you already know, the recovery trial, UK-based trial is ongoing. Already they gave report or guidelines for studying the the dexamethasone report or use of beneficial effects of dexamethasone. So with all this, I want to conclude. Now I ask or invite question. If any, you can mute yourself and ask question. If you have anybody, am I audible?
স্যার শোনা যাচ্ছে?
If you have any question, seeing any chat box, any question. If you have any question, you can unmute yourself and you may ask question.
স্যার।
আসসালাম সোহেল, হাউ আর ইউ?
স্যার ভালো আছি স্যার।
বাসার সবাই কি ভালো আছে?
স্যার এখন ভালো আছে স্যার।
ওকে, থ্যাংক ইউ। আস্ক ইউর কোশ্চেন।
স্যার আপনি একটা স্লাইডে দেখাচ্ছেন স্যার ফেরিটিনের সাথে মর্টালিটির একটা বিষয়, যে ফেরিটিন বেশি থাকলে তার মর্টালিটি বেশি হবে। ফেরিটিন কেন বাড়ে স্যার ইন কেস অফ COVID-19?
Ferritin may be considered as an inflammatory marker. So far, I could know. So, this ferritin is raised, maybe raised due to or maybe a reflection of a increased inflammation.
স্যার আসসালামু আলাইকুম স্যার, আমি তানভীর বলছিলাম স্যার।
Tanvir,
স্যার ওই যে 3টা ফেজে যে ভাগ করছেন স্যার, ওটা ডিউরেশনটা কি হবে স্যার?
first phase is 7 days, mild symptom, then moderate symptoms 7 days onwards. Next 7 or 10 days, then systemic inflammatory response, last phase.
স্যার কর্টিকোস্টেরয়েডে ডেক্সামিথাসোনের স্যার ডোজিংটা আপনার স্লাইডে সম্ভবত স্যার 6 মিলিগ্রাম দেখছি স্যার। এটার ডোজিংটা রিকভারি ট্রায়ালে কি স্যার 6 মিলিগ্রাম?
রিকভারি ট্রায়ালে 6 মিলিগ্রাম করে দিচ্ছে ওরা।
ঠিক আছে
স্যার, আমার একটা কোশ্চেন আছে স্যার।
জি
স্যার ওই যে বলছিলেন একটা ইয়েতে আমি প্রায় অর্গানাইজ শুনি স্যার, যদি অ্যান্টিভাইরাল দিতেই হয় তাহলে স্যার শুরুতে দিয়ে দেওয়াই ভালো, এটা বলেন অনেকে স্যার। প্রশ্ন হচ্ছে আমরা তো জানি না ওই পেশেন্টটা কি খারাপের দিকে যাবে কি যাবে না, তো সব রোগের অ্যান্টিভাইরাল দেওয়াটাও তো মুশকিল। আবার দেখা যাচ্ছে 6-7 দিন পরে যাই বা 8তম 9তম দিনে যে সবচেয়ে বেশি খারাপ হচ্ছে। এই ক্ষেত্রে কি করণীয় স্যার? আমরা কি ব্লাইন্ডলি অ্যান্টিভাইরাল দিব কি নাকি কি করবো স্যার?
There are two aspects of this answer of this question. First aspect is what is the recommendation? Recommendation is start when a patient is hospitalized with mild or moderate symptoms. Start with the first day. This is one thing. Second thing, if we consider the rationality, you must have to use your arms or armamentariums in day one. If the viral replication is more and more, if your enemy is increasing day by day, then how will you combat with them? So, recommendation is also there with day one, and also the rationale for using antiviral to kill the virus at the primitive step or the earlier step. So, remdesivir or antiviral use should be earlier.
থ্যাংক ইউ স্যার।
স্যার আমার তো এখানে সাপ্লিমেন্ট আছে স্যার। প্র্যাকটিক্যালি আমাদের হসপিটালে কোভিড পেশেন্ট ভর্তি হয়, আমরা দেখি স্যার রেমডেসিভির আইসিইউতে গেলে তখন দেয়, এছাড়া দেয় না আমাদের যেটা প্র্যাকটিস এখন। আর ফ্লাভিভিরের এখানে রোল কি স্যার? ফ্লাভিভিরটা দেখা যাচ্ছে যে স্যার ওরা বলে মাইল্ড টু মডারেট হইলে দেয়, আমরা প্র্যাকটিক্যালি দেওয়া হচ্ছে হসপিটালে এরকম, কিন্তু আমি কখন ফ্লাভিভির দিব কখন রেমডেসিভির দিব এখানে কোনো ক্লিয়ার কাট কোনো গাইডলাইন আছে?
To be honest, I don't know any evidence or any data regarding flavivir, so I couldn't answer your question. But remdesivir, you have to use. It is ideal to use in earlier. So far I know in CMH they are using remdesivir in earlier, and some cases, as we know, those are diagnosed. Those are treated as a mild symptom, but they are treating remdesivir as well as plasma therapy earlier. Consider earlier.
এটা আমিও দেখি ইয়াতে বিভিন্ন জার্নালও তাই বলে, কিন্তু আমাদের দেশে করোনা ডেডিকেটেড যে হসপিটালগুলো আছে এখানে সবাই প্র্যাকটিস করে যখন স্যার আইসিইউতে যায় তখন, বা সিভিয়ার ইলনেস না হলে দেয় না। এটা কি স্যার কস্টের জন্য দেয় না নাকি আদার্স কোনো?
I don't know. It should be started earlier. And Azmul.
আসসালামু স্যার। এই কোশ্চেনটা আসলে ফেভিরাপিরাভিরের জিনিসটা হলো জাপান থেকে, মানে জাপানি মেড, এটা নিয়েও কিছু স্টাডি হচ্ছে অ্যাট দ্য সেম টাইম রেমডেসিভির, যেহেতু আমরা করোনা নতুন একটা জিনিস, এই কারণে একদম এক্স্যাক্টলি ড্রাগস আমাদের কাছে নাই। তো কোথাও কোথাও দেখা গেছে ফেভিরাপিরে কাজ করতেছে, কোথাও কোথাও রেমডেসিভিরে কাজ করতেছে। তো প্রত্যেকের জন্য নিজেরটা বলতেছে যে আমরা আর্লি স্টেজে দুইটা ড্রাগসই বেসিক্যালি মাইল্ড টু মডারেট কেসে স্যার আসলে দেওয়ার কথা, কারণ ওই টাইম গুলাতে ভাইরাল লোড থাকে এবং এটা ভাইরাল রেপ্লিকেশন প্রিভেন্ট করে। সিভিয়ার কেসে যখন পেশেন্ট যায়, মেইনলি সিভিয়ার কেসে যায় হাইপার ইনফ্লেশনের জন্য বা ইনফ্লামেশনের জন্য, রিয়েকশনের জন্য, আমাদের ইমিউন রিয়েকশন বাড়ার জন্য। তো সেই ক্ষেত্রে আসলে ওই ড্রাগসগুলোর কোনো ভূমিকা নেই। ফেভিরাপিরাভিরের ব্যাপারেও কিছু স্টাডি বাংলাদেশে হয়েছে, কুমিল্লা মেডিকেল কলেজে ফেভিরাপিরাভির ইউজ করা হয়েছে, ইভেন সিএমএইচও কিছু জায়গায় 50টা পেশেন্টের উপর ফেভিরাপিরাভির ইউজ হয়েছে এবং তারা দেখাইছে ভালো কাজ করে। আবার রেমডেসিভিরও অনেকগুলো জায়গায় ইউজ হয়েছে, সব জায়গায় দেখাইছে ভালো হয়েছে। এই জন্য স্যার এক্সাক্ট কোনো ইন্ডিকেশন নাই যে কোন ড্রাগসটা কখন কোথায় ইউজ করতে হবে। দুইটা ড্রাগসই সমানভাবে ইউজ করে, যে যেটা প্রিফারেন্স দেয়। তবে একটা জিনিস যেটা অনেকেই প্রিফারেন্স দেয় সেটা হচ্ছে যেহেতু ফেভিরাপিরাভির ওরাল ড্রাগ, সেজন্য ইন হসপিটালের আগেই অনেকেই শুরু করতে পারে, আর রেমডেসিভিরটা হসপিটাল অ্যাডমিশনের পরে শুরু করে অনেক। থ্যাংক ইউ স্যার।
Okay, you have any question or Kamal?
যে মিথাইল প্রেডনিসোলন আর আর হচ্ছে ডেক্সামিথাসোন, এই দুইটা নরমালি ইউজ করা হচ্ছে। তো এখন স্যার কোনটা, এখন অনেকেই তো মিথাইল প্রেডনিসোলন ইউজ করে, অনেকে ডেক্সামিথাসোন, এখানে স্যার আসলে কোনটা ইউজ করলে ভালো?
Dexamethasone is evidenced by a trial, recovery trial, and you can use methylprednisolone also. But dexamethasone, so far I know, it has a beneficial effect in cardiac patient. So you can use dexamethasone.
স্যার আমরা যেহেতু ওরাল ফর্মে আছে স্যার মিথাইল প্রেডনিসোলন, আর তো মানে অথবা পেশেন্টকে যদি বাড়িতেও থাকে আমরা কি ইনজেক্টেবল ডেক্সামিথাসোন দিয়ে দিতে পারি?
Use your suitabulon, use on that drug that is available or easy to manage or arrange. You can use dexamethasone.
জি স্যার, থ্যাংক ইউ স্যার।
If no question, we can conclude today lecture. Ruben, we can stop here.
স্যার আর মনে হয় কোশ্চেন নাই কারো, তাহলে